Hello, and welcome to this presentation by the National Patient Safety Team at NHS Improvement. We have produced this short talk for NHS trusts to help them understand what their local learning from death policy should include. You can use this guide to help update your existing policy, create a new policy, or to check that your current policy is consistent with national guidance. My name is Matt Fogarty, and I'm one of two Deputy Directors of Patient Safety in the National Patient Safety Team. If you have any questions once you've watched this presentation, please email us at patientsafety.enquiries@nhs.net. The National Quality Board published the first national guidance on learning from deaths in March 2017. This represented the consensus advice from all the bodies represented on the National Quality Board, including NHS Improvement. NHS Improvement is also a member of the Department of Health's Learning from Death Programme Board, which was created to coordinate improvement in how the NHS learns from the care provided to those patients who die. As part of this programme, NHS Improvement has particular responsibility for supporting NHS trust boards to implement the Learning from Deaths guidance. The guidance includes a requirement for NHS trusts to have published organisational learning from deaths policies by the end of September 2017. You can find out more about our role and other resources on the dedicated Learning from Death page on the NHS Improvement website. In this presentation, we will cover the context for the Learning from Deaths guidance and the expectations in relation to NHS Trust policies, including the recommended content for those policies. Let's start with some background. In 2016, the Care Quality Commission carried out a review of how trusts review and investigate the care provided to patients who die while under the care of the NHS in England. The CQC spoke to NHS staff and more than 100 families and gathered evidence from charities and all NHS trusts, including through specific visits to 12 individual trusts. The CQC made a number of important findings in relation to learning from deaths in NHS care. In particular, they found that families and carers are not treated consistently well when someone dies, meaning that they don't always receive appropriate bereavement support. Too often, they are not given the opportunity to provide feedback on the care that was received by their loved one, and too often they are not involved appropriately in investigations or informed of the outcomes. The CQC also found that there is variation and inconsistency in the way that trusts become aware of deaths of patients in their care, meaning that opportunities to review deaths in a timely way and to engage all the organisations involved in the person's care are missed. Trusts are inconsistent in the approach that they use to determine when to investigate the care provided to the deceased, meaning that opportunities to learn are missed again, and conversely that deaths are sometimes investigated when there is little to learn. And the CQC also found that the quality of investigations into care provided to the deceased is variable and generally poor. Again, this means that opportunities to learn and improve care are missed. Overall, the CQC found that there was no single consistent framework for the NHS to follow to guide how it reviews the care provided to those that die. The CQC made a number of recommendations for how the NHS should improve the way that it learns from the deaths of people in our care. These recommendations were accepted in full by the Secretary of State. Subsequently, in March 2017, the National Quality Board published the National Guidance on Learning from Deaths. This sets out a framework for NHS trusts and responds to the CQC's recommendations. You will of course recognise that much of the learning from deaths work is part of a wider direction of travel within the NHS, aimed at supporting the whole service to increase transparency, ensure candour when things go wrong, involve people and their families in their care and in understanding how to improve their care, to foster a culture of continuous learning and improvement across the whole of the NHS, and to strengthen leadership across the NHS. Particularly important to this wider work is NHS Improvement's National Framework for Improvement and Leadership Development, which is known as Developing People, Improving Care. This is an evidence-based national framework to guide action on improvement skill building, leadership development and talent management for people in NHS-funded roles. And you can find out more information about this through the link in our useful resources slide at the end of this talk. It is important to approach the Learning from Deaths guidance in the context of this improvement framework. There is little point in looking at the care provided to patients who die if we don't then use the information that we generate to support continuous improvement in the quality of the care that we provide to patients. Before we get into the detail of the contents of trust policies, we thought it might be helpful to have a quick recap of some of the important definitions we use that are relevant to the Learning from Deaths work. We define a patient safety incident as any unintended or unexpected incident which could have or did lead to harm for one or more patients receiving NHS care. A case record review is a structured desktop review of a case note carried out by clinicians to determine whether there were any problems in the recent care provided to a patient. Serious incidents are defined as events in healthcare where the potential for learning is so great, or the consequences to patients, families, carers, staff, all the organisations are so significant that they warrant using additional resources to mount a comprehensive response. Typically, these include patient safety incidents that led to death or severe harm, or where urgent action had to be taken by clinicians to prevent death or severe harm. They also include allegations of abuse, never events, incidents that threaten an organisation's ability to function, or incidents that lead to a major loss of confidence in an organisation. An investigation is defined as a systematic analysis of what happened, how it happened, and why, usually following an adverse event, where significant concerns exist about the care that was provided. Investigations are distinct from case record reviews in that they consider a wider range of evidence and use a variety of tools and analytical techniques. A death due to a problem in care is a death that has been clinically assessed using a recognised method of case record review, where the reviewers feel that the death is more likely than not to have resulted from problems in care delivery or service provision. In many cases, judging that a death was due to problems in care will be a finely balanced judgment that others may not agree with. This is not the same thing as defining the cause of death in the legal sense. Okay, in the next part of the talk, we'll go over some of the advice we would provide to trusts in relation to what we think they should include in their local learning from death policies. As you know, trusts are required to publish an updated policy on how they respond to and learn from the deaths of patients by the end of September 2017. At a high level, these policies should include your trust's process for reviewing the care that you provide to patients who die, including how you define which patients are considered to be under your care and therefore are potentially in scope for review, how individual deaths are selected for review, and the method that you use to do those reviews. You should set out how your trust will respond to certain categories of deaths, specifically the deaths of people with learning disabilities, people with severe mental illness, infants or child deaths, stillbirths, and maternal deaths. You should set out how your trust decides which deaths require an investigation under the serious incident framework as opposed to a review. And you should also set out how your trust engages with and supports bereaved families and carers. The next few slides go through each of these topics in turn. We suggest that your policy should provide details about your trust's processes for recording that patients have died. This should include the details of where and how quickly staff should internally report that a patient has died, the process for identifying and contacting other organisations that need to know about the death, the process for informing the coroner about deaths, and the process for recording deaths notified to the trust from other sources. The policy should also cover how your trust determines which patients are under your care or are within scope for case record review. For example, for how long after a patient is discharged will your trust still consider the patient in scope for case record review if that patient dies? For acute trusts, we have suggested 30 days after discharge, but your policy may wish to extend this period. We suggest that your policy should state when your trust will trigger an automatic review of the care provided to someone that dies. The National Learning from Deaths guidance specifies a number of instances in which review is always expected. For example, all deaths where relatives or carers have raised concerns about the care that was provided, and all deaths following elective procedures. Trust policies should set out exactly under which circumstances they will always review care. The policy should also set out how your trust will identify other deaths to review. Again, the national guidance proposes a number of categories, including deaths in services or areas where you are undertaking quality improvement work, or a random sampling of deaths across each day of the week to look for under-recognised issues. As part of your policy, you should also include information on the review methodology that you use. For most acute organisations, it's likely that this methodology will be the structured judgment review method or a methodology based on the PRISM studies. Details about both of these are available on our webpage. For other types of deaths, other methodologies are appropriate. It's worth noting that work is currently ongoing to develop further advice on case record review for trusts who are providing mental health services. The Learning from Death framework specifies that for certain categories of patients, reviews of death are mandatory and must be carried out in specific ways. Firstly, reports and case studies have consistently highlighted that in England, people with learning disabilities die up to 20 years younger than people without learning disabilities. The Learning from Death framework specifies that all deaths of inpatients, outpatients and community patients with learning disabilities should be reviewed in order that learning from these deaths can contribute to service improvements. The Learning Disabilities Review, or LEADER programme, commissioned by HQIP, has an established and well-tested methodology for reviewing the deaths of people with learning disabilities. Where the LEADER programme has been rolled out, your local lead should notify the LEADER team about any deaths of people with learning disabilities. Deaths are to be reviewed using the LEADER programme methodology. This takes a wider approach to understanding the person who has died and their needs, and not just the final episode of care at the end of their life. However, we are learning that conducting a structured judgment review or other type of mortality review of the last episode of care can provide useful information to add to the LEADER review. Trusts are therefore advised to review the last episode of care using SJR or another method, and then refer the death for LEADER review as well. If the LEADER programme is not yet available in your area, please use structured judgment review or another robust methodology in the meantime. For the purposes of reviewing the care provided to people with severe mental illnesses, the Royal College of Psychiatrists, NHS England and NHS Improvements are working to develop detailed advice on how reviews should be conducted. A group has been assembled to develop this advice, which includes clinicians and managers from across the NHS. Until this advice is available, trusts should use SJR, PRISM or another appropriate method to review the deaths of people with severe mental illness. Reviews of all infant and child deaths are mandatory. These should be undertaken in accordance with the Working Together to Safeguard Children guidance and should follow the current child death overview panel processes. NHS England is leading work to update this process, and further information will be made available in due course. All perinatal deaths should be reviewed, and a new perinatal mortality review tool is being developed to support this. Trusts should use this once it is available. It is very likely that maternal deaths and perinatal deaths will meet the definition of a serious incident and should be investigated accordingly. As a minimum, a review is needed to establish if there are any causes for concern. The Learning from Deaths guidance emphasised the need to consider both reviews of the care provided to patients who die and the more in-depth process of serious incident investigation. Serious incident investigations are carried out where there is a need to invest significant time and resources into understanding why something has happened, so that work can be undertaken to reduce the risk of the same thing happening again. The decision to initiate a serious incident investigation is a judgment call, which will depend on the circumstances in question. But an investigation can be initiated immediately after an adverse event, when it is recognised that something has gone wrong, or when evidence that an adverse event has occurred is identified by a case record review. Review and investigation do not have to be sequential, and an investigation does not need to be preceded by a review. Trusts should be clear how their learning from death process links to their serious incident policy, and how staff should trigger an investigation if the results of a case record review indicate that an investigation is required. Trust policies should also set out how information about serious incident investigations into the care provided to patients who have died is collated and published. One of the most important transformations required in response to the Learning from Death policy is improving the way that carers and families are engaged with after a death. This is therefore a critical part of your trust policy. Chapter 2 of the National Guidance on Learning from Deaths states that providers should meaningfully engage and compassionately engage with bereaved families and carers at all stages of responding to a death. This means that trusts should provide a clear, honest and sensitive response to bereavement in a sympathetic environment. They should offer a high standard of bereavement care, including support, information and guidance. Trusts should ensure that families and carers know that they can raise concerns about the care provided to the deceased and be given opportunities to do so. And where they have concerns about care, know that this will trigger a case record review and any other appropriate action. Trust should involve families and carers from the start and throughout any investigation as far as they want to be involved. And trust should offer to involve families and carers in subsequent quality improvement activities. So that covers the main areas that NHS Improvement would advise you to include in your local learning from deaths policies. We have also developed a template learning from deaths policy as a further guide for trusts. You can find a copy of this on our Learning from Deaths webpage. The template expands on some of the themes discussed in this presentation and provides one example of how your policy could be structured. It's not compulsory to use this template, and trusts can use discretion in adapting or making use of this to fit their own needs. It is also important, though, to read this in conjunction with the national guidance on learning from deaths.